Welcome. Good morning. And thanks for being here with us today. We've got a great webinar titled Navigating the Path to CMS Reporting, Lessons and Resources to Support the Journey of Reporting Viral Suppression Data. Again, I want to welcome you and thanks again for spending a little bit of your Monday morning here with us. And we will get rolling here right away. Next slide. Just a quick reminder, this webinar and our project is supported by HRSA, and what you hear today doesn't necessarily reflect the official views or an endorsement by HRSA or HHS. Next slide, please. And my name is Van Wilson, and it's such a pleasure to meet you today. I am with the National Association of State and Territorial AIDS Directors, or NASTAD, as you probably have heard of us before, I hope. I'm Associate Director on our Health Systems Integration team, and I've worked really closely over my 9 months so far at NASTAD on this project. And I'm really excited that you're here to learn some more about it today. Next slide. Some quick little housekeeping. If you haven't learned already, we have disabled audio and video for our participants since we're just in a meeting room today. And we do have our Q&A module open, which I hope, unless you've been living under a rock for the last 4 years, I think everyone's very adept at using Zoom at this point. So please use our Q&A module for your questions and then chat with other participants. We'll keep that in the chat box there. And again, if you're just joining us here, I've seen quite a few in the last few minutes here. Just drop your name and your organization there in the chat. We love to see who we are working with today. Next slide. So really quick, our objectives today. The biggest one is we're going to introduce our initiative, which HRSA has called Building Capacity to Improve Viral Suppression Data in Medicaid. We're going to understand the core features of the HIV viral load aggregate data measure. It is included in the Medicaid Adult Core Measure Set. We're going to learn what it does not measure, and its potential for impacting quality of care for Medicaid beneficiaries living with HIV. We are then going to explore what it takes to report this measure. What data does it take? What available resources are necessary? And what can NASTAD and our team do to help you report this measure? And then finally, we're going to hear from two of our greatly esteemed state colleagues, Joyce and Parker from Iowa and Maryland, respectively, and hear a bit about their journey about reporting this measure. Next slide. So really quick, just our agenda. We are in the midst of our welcome and housekeeping. We're going to jump to our project overview, have a little bit of time for Q&A, and then we're going to hear from our state teams. We are also going to have a little bit of moderated discussion, and then, as is always the case these days, we're going to close out with some audience Q&A and a bit of closing. And we're crossing our fingers. Hopefully we have Dr. Cheever joining us from HRSA HAB for our closing. And let's roll into it. I'm going to hand it off to my colleague, Kathleen Davies.
Thank you, Van.
Yep.
Hi, my name is Commander Kathleen Davis, and I serve as the Senior Policy Advisor within the Division of State HIV/AIDS Programs, and which is in the HIV/AIDS Bureau and the Health Resources and Services Administration. Try putting all of that on a business card. I also have this wonderful opportunity to be one of the HAB staff members on the Building Capacity to Improve Viral Suppression Data in the Medicaid initiative. I would like to take an opportunity to thank HAB and HRSA leadership for recognizing the importance of this work. It's my pleasure to welcome you. I know that you'll find the information provided very helpful and valuable. I would like to also thank the Centers for Medicare and Medicaid Services for being a continuous partner in this and so many other initiatives that benefit our recipients and clients. Finally, I would like to thank NASTAD and their partners, AcademyHealth, UCSF, and Georgetown University in the work they have done so far to help our recipients develop the processes and resources needed to report the HIV viral suppression measure to CMS. NASTAD, as you'll learn, stands ready to bring more recipients into this project, and that is the ultimate goal, to bring more recipients into this project and meet them where they are so that they can achieve the goal of reporting the measure. So I will now turn it over to Dr. Deirdre Stockman, Director of the Division of Quality and Health Outcomes for the Center of Medicaid and CHIP Services at CMS, to share a few words. Ma'am?
Thanks so much, Kat. I always feel a little underdressed when you're in your uniform.
On a Monday.
It's great
on
to,
a Monday.
On a Monday morning. It's great to join you all. I would like to add my gratitude to HRSA for supporting this important effort. We're so fortunate to have you as wonderful partners. And to NASTAD and the technical assistance team for all the work that you are doing with states to improve ability to collect and report the HIV viral load suppression measure. And of course, to the states who are working hard to establish the data linkages and processes to make that possible. I spend a lot of my time looking at and thinking about quality measures and performance rates across and within states, but I don't do that just because I love to look at spreadsheets or the data in and of themselves inspire me. I do it because the data we get from quality measurement, like the HIV viral load suppression measure, are essential tools to help us ensure that all people are getting the care they need. The ability to look at performance on this measure in particular across and within populations and communities in your states will help us to focus, work with partners to improve care and improve lives for people living with HIV. This is incredibly important work. Thank you all for doing it, and I'll hand it back to Dan.
Thanks, Deirdre. Next slide. So just a couple slides about NASTAD if you haven't heard of us yet. Next slide. Our mission is to advance the health and dignity of people living with and impacted by HIV/AIDS, viral hepatitis, and the intersecting epidemics by strengthening governmental public health and leveraging community partnerships. We envision a world that is committed to ending HIV/AIDS, viral hepatitis, and the intersecting epidemics. Next slide. We are a membership organization, and we serve all 50 states, District of Columbia, Puerto Rico, the U.S. Virgin Islands, 7 local jurisdictions, and our U.S. Pacific Island jurisdictions. And we just had our annual member meeting just a couple weeks ago, and many of you who have joined us here today were able to attend with us there. All right, let's get into our content. Next slide, please. Again, my name is Van Wilson. This is our webinar on building capacity to improve HIV viral suppression data in Medicaid. Next slide. I'm going to start with just a little bit of context before we jump in. So there have been 2 major initiatives, federal efforts to grow the connections between public health, HIV surveillance specifically, and Medicaid systems of care, including Ryan White. This work has resulted in really important advancements in the connectivity between public health and Medicaid. And a handful of states began reporting the HVL-AD shortly after this first affinity session or affinity group here that you see that started in 2016. This was a federal effort co-led, and get ready for some acronyms here: CDC, CMS, HRSA, the HHS Office of HIV/AIDS and Infectious Disease Policy, and NASHP, or the National Academy for State Health Policy. This was really the first affinity group with a specific goal to increase collaboration between public health departments and state Medicaid agencies, and 19 states participated in that. Fast forward a little bit to what we're talking about here today, 2021, HRSA started this SPINS initiative to grow the same sort of thing. NASTAD was thrilled to receive the award, and since then working with our partners to establish our initial learning collaborative, which you see there in dark blue. We had 8 states participating in that, and we're just about ready to wrap up a 2-year cohort, working with them, 2.5-year cohort. And now we're expanding our efforts to recruit and support even more states to report the HVL-AD measure, which we see here in yellow. And presently we're talking with about 8 to 10 states that are working towards reporting this measure, and our work with that began back in January 2023 to this day. Next slide. I've got a couple quick little national maps here just to show you. So this is the state participation. The states with the diagonal lines here participated in the 2016 affinity group. The states in blue were part of our learning collaborative. And the 10 states here in yellow are newly engaged or newly exploring this work. Next slide. So what's the current state of reporting given all of this work? So For measurement year 2022, which was just reported in January of 2024 for the Adult Core Set, this is the state of affairs. So within there, we had 11 states in purple there who officially reported in the Adult Core Set and showed up in the documents and the reports there. And I have a link to the 2024 chart pack if you're interested in seeing that. We know through our work that 4 other states calculated the measure but didn't get it reported. And presently, we're working with 9 additional states here to report HVL-AD. Next slide. Next slide, please. So I've mentioned a number of this already. And really what I want to draw your attention here to is this kind of soft goal of 25 states reporting HVL-AD annually. And that's an important number for considering this as a required measure for each state. It won't make it mandatory, but there is an opportunity to consider this as a required measure. Next slide. I just want to take a moment and really highlight and thank our partners for the incredible work that we've done together on this project. So all of whom are on this call here today, and you'll hear from our colleague Elizabeth Cope here next. So AcademyHealth brings a wealth of expertise in health services and policy research, expertise in dissemination, implementation, Medicaid policy. UCSF, Health Qual, really helped out with the Learning Collaborative and the multi-site evaluation. And then finally, Georgetown University brings really just a wealth of expertise on the technical side of things. So as I mentioned before, we've done a Learning Collaborative. We are now starting a community of practice, which is a bit more dynamic. And we have continued to offer technical assistance. We are doing our full site of multi-site evaluation, and now we are disseminating this work. Next slide, please. I will hand it over to Elizabeth here to really dive into the measure.
Thanks so much, Van. I appreciate it. All right, so it is my pleasure to spend a little time talking about what this measure is and where some of the opportunities are for it to make a difference. So let's go to the next slide. Great. So here's the ground I'm going to cover. First, I'm going to walk through at a high level what this measure is, and then we're going to look at why reporting it is valuable. And before I jump in, I do want to be clear that I'm going to be talking specifically about the facility level performance measure, HVL-AD. I'm not going to be talking about the underlying data that are shared or used to calculate the performance measure. In other words, like viral suppression data writ large. Today, we're focused pretty specifically on HVL-AD, what it is, what it isn't, and the valuable contribution it can make to improving the lives of those with HIV, improving our healthcare system, and improving public health overall. Next slide. All right, we don't have time to walk through all of the specifications, so I'm just going to focus on the numerator and denominator for today. When we look at this, you can see that at face value, it's looking at the proportion of beneficiaries with a diagnosis of HIV who have a viral load less than 200 copies per milliliter at their last viral load test in the measurement year. But I would caution folks not to conflate this with viral suppression rate generally, because it's not what it is. It's not a surveillance measure. This is the quality of care performance measure. So it's a way to assess if care providers are performing as they should. So there are some additional specifications added into the denominator that are relevant to attribution and accountability. And so we're going to dissect that together. Next slide. So first off, when we're looking at the beneficiary population of the provider to whom this measure is being applied, the HIV diagnosis is prior to or within the first 90 days. So we're not including all of their Medicaid patients with HIV. We're looking for the most part at prevalent patients or those diagnosed at the very beginning of the year. So we're removing most incident patients who may very well be in need of care plans for viral suppression. But as a measure of care quality performance, we're including people whose diagnosis providers are likely to both know about and have time to adequately manage and respond to during the measurement year. Next slide. Now, we also see that we're looking at beneficiaries who had a medical visit during the measurement year. And of course, not everyone goes to the doctor every year, so we're further reducing the number of people in that denominator by only looking at the people who are in care. So the public health person in you might think to yourself, why are we doing that? Oftentimes the people who need the most help or who need the most tracking are the ones lost to care. But remember, again, this is a quality of care measure. So we're holding providers accountable with this measure. And we care about the people that they're touching. And we also have to know how to attribute which patients to which facilities. And one way to do that is by linking patients to providers through a visit that takes place during the measurement year. And then a particular patient was under a particular provider's care during that year. But what does the rest of that statement mean? Next slide. So when we fan out a little bit, we can see that the medical visit must occur within the first 240 days of the measurement year. This is to give the provider time to respond. So if the visit and perhaps subsequent viral load test occurred during the end of the year, that wouldn't give the provider much time to respond with a plan of care to help the patient get back on track and still be within the measurement year. If this is a measure of quality of care, it should be specified in a way that allows evaluation of whether providers respond effectively to patients in need of support, rather than penalizing providers for information received either too late for them to act upon or where they are acting upon it, but you can't actually see it in the measurement year. So when measures are developed for the accountability context for CMS programs, it means they can be used in programs like public reporting and value-based purchasing, which means provider payment can be adjusted based on their measure scores. Do these kinds of measures have to be used this way? No. Are they always used this way? No. But it means these kinds of uses would be acceptable and appropriate for the measure. And so that's why these considerations get factored in. And it's why you see these kinds of specifications getting built into these measures. Next slide. So now that you have a better picture of what the measure does and doesn't measure, let's talk a little bit about why reporting it is valuable. Next slide. Yep. So the bottom line is that it's important. Viral load suppression is a key indicator. So we know that individuals who attain and sustain viral suppression earlier in the course of their HIV infection have better outcomes and generate lower costs. We also know that they have effectively no risk of sexually transmitting the virus to an HIV-negative partner. So this is an incredibly important outcome to track. But again, this is a measure of provider quality of care in the Medicaid context. So it's true that factors beyond the clinic matter and can matter a great deal. But providers have a key role to play in improving viral suppression rates through prescription of antiretrovirals and monitoring of viral load. So they are a key player here. And Medicaid covers about 40% of all persons with HIV in the US. So focusing on quality of care in Medicaid is potentially a major route to improving this vitally important outcome for people with HIV. And it's not only when you think about the people impacted and the providers delivering care, but Medicaid's channels for uptake of the measure are incredibly diverse and wide-ranging as well. There are a number of powerful policy levers available to the agency through its financing, contracting, and convening capacities that could broaden the measure's reach and heighten its impact. So this measure, with its particular specifications and designed for its particular contextual application, has the potential to make a real difference. Next slide. And it's important to highlight that this measure also helps to advance a number of national and state strategies. Now, obviously, at the top of the list would be the Ending the HIV Epidemic Initiative, as well as the National HIV/AIDS Strategy. But it's important to note that HVL-AD also advances national and state quality strategies. So I want to take a look at that in a little more detail. Next slide. So when we look at the national quality strategy, there are 4 major domains. So if we start with equity and engagement, and I'm just going to highlight a few points here. This measure is targeting a key subpopulation within Medicaid beneficiaries, And as an outcome measure, it also promotes patient-centered care and supports patient-provider concordance on care plans. If we look at outcomes in alignment, as we know, this measure is an outcome measure. It's also a measure that could be implemented across a range of care settings. So it could be adopted in managed care organizations, accountable care organizations, fee-for-service, et cetera. And so it could promote alignment across a range of Medicaid programs. And looking at interoperability and scientific advancement, HVL-AD promotes uptake of a consensus-endorsed performance measure, and it could be used at both the clinic and managed care levels to promote data-driven quality improvement. And finally, if we look at safety and resiliency, this measure is about preventing transmission and strengthening our public health infrastructure. So by building stronger relationships and quality improvement infrastructure between Medicaid and the Department of Health, we're positioning our public health and healthcare systems for greater resiliency that would translate to a broad range of health topics extending far beyond HIV. So I walk through this to show that not only are we doing a lot to improve the lives of people with HIV and this measure, with this measure, and to advance the national strategies that we have for HIV, this measure is intimately aligned with our most closely held goals for improving the quality of our healthcare delivery system as a whole in this nation. Next slide. So I want to close by sharing some concrete thoughts on the way this measure could help move the needle. So far, we've talked in a high-level way about the importance of the measure, the way it aligns with our national strategies. That doesn't tell you how this measure could make a difference with the toolbox that we have. So let's talk about a couple of examples. Work on this measure could bring about greater collaboration between Medicaid, HIV surveillance, and Ryan White programs. And this type of coordination could enable Medicaid and Ryan White programs to delineate potential service overlaps, reduce unnecessary costs, and avoid duplication of services. In addition to infrastructure benefits, interagency collaboration offers service delivery benefits as well. So as an example, the measure could be used to identify performance gaps related to in-care status. So for example, in 2021, North Carolina used the measure to identify differences in viral suppression between racial and ethnic groups. Upon identifying those, they used bridge counselors to engage people with HIV to support better access to care. And finally, the measure can also be incorporated into Medicaid's performance improvement programs. As an example, Louisiana incorporates the measure as part of their mandatory managed care plan reporting and has seen sustained improvement within individual health plans as well as in aggregate over time. And then lastly, California and Mississippi have both incorporated the measure in their performance improvement projects as part of their managed care contracts to drive contractually obligated benchmarked improvement among managed care plans. So hopefully this gives you a picture of how the measure could be applied in Medicaid programs to drive real change on the path to ending the HIV epidemic and building a better national healthcare system. So it's now my pleasure to turn things over to Kanikwa, who will dig into the particulars of what all is involved in reporting this measure. Thank you.
Awesome. Thank you, Elizabeth. Hi, everyone. Good morning still. So my name is Kanikwa Outlaw, and I will be just giving you a high-level overview of the journey to reporting the HVL-AD measure. Next slide, please. So as you can see here, we've outlined what we hope is a good visual representation of the key milestones for reporting a viral load suppression measure to CMS. And so on this slide, we acknowledge the fact that there are several steps in between these major checkpoints that we've determined are useful to getting to doing the reporting. But we also want to acknowledge that each state starts in a unique position. And so throughout the next couple of slides, I will touch a little bit more on these checkpoints. And you may notice that there may be some light bulbs that might go off because this is where your state may currently be in terms of getting closer to reporting the measure. And there may be some roadblocks that are along the way that you might identify throughout these next few slides. And I hope that not only does this help to give you an idea of what expectations are, but we also hope that with the resources and support that we can provide, that you'll be able to feel more confident in being able to do so. Next slide, please. So the very first checkpoint, and I want to be clear here that this is not always a linear process between the very first checkpoint and the final checkpoint, which is what we would consider not only routine reporting, but using the data from that reporting to make really important decisions. But it is clear here that this is the first checkpoint, one of the most important ones, which is not only understanding why it matters to do reporting in your state, but understanding your organization's context to support being able to do that. Elizabeth did a really great job in outlining overall the value for reporting. And that value for reporting is only as important as really understanding how your state is at a level of readiness in order to do so. So one of the most important things that I would say in this first checkpoint is really understanding who's going to support the work. Who are those champions? What stakeholders have been identified? Who are the people that have the decision-making authority and are going to do the work and support the work for reporting? It's also important to consider what are the barriers or blockages to reporting. So this could be people or processes. So really getting a good understanding of what those are and being able to name them and document them so that you can mitigate any of those that may hinder your process. Also understanding the specifications for doing the work. CMS has a really great technical specifications guide that is really going to help you along the way, but also understanding what that looks like within your current organizational context to ensure that this progress can be implemented into your current workflow or adjusting that if need be. In addition to that, just thinking about who's going to manage each aspect of the reporting process. So what do those roles look like? What does that time and effort look like? And really just having a good understanding of that. And in addition to that, that estimated effort, what does it look like right now to have conversations between Medicaid and surveillance about who's going to do what work, and not just for right now, but what that looks like in the longer term. Next slide, please. So in this checkpoint, we also try to just give a good idea of what it looks like to understand your state's legal or data landscape. And so here, data sharing really comes into play because just having that regulatory infrastructure in place is really key to be able to do this level of work. So one of the first questions that you might want to ask or be able to answer is, is a data sharing agreement in place? And if it is currently in place for other projects that you may have endeavored between Medicaid and surveillance or other organizations along, similar veins, what is encompassed within that data sharing agreement that would allow you to perform this level of work within this project? And if a data sharing agreement is not in place, then there are some really important questions that you might want to consider as you think about developing one that's going to meet the needs of this project. Next slide, just one skip forward. Thank you. So the first question is who? Who's going to be responsible for doing the match? What level of access are they going to have to the data for the matching process? Who's going to be sending the data across agencies to be able to do the work? Next slide. What tools are going to be used to conduct the match? That may not necessarily be explicitly defined within your data sharing agreement, but it is a good question to ask because in a later slide, I'll talk about, why it's important to be able to answer that question. And one of the even more important questions is what data variables are going to be needed to do the match. And that should be explicitly outlined within that data sharing agreement. Next slide. Also thinking about when, how often are the matches going to be taking place and what time period does that data access last? Just thinking about the fact that, things may change. CMS may update guidelines at some point. You may have changes within your own organizational structure that might really require you to expand or expound upon what that level of data access looks like. So just making sure that you account for that within that data sharing agreement so that those surprises that may come down the line don't impact this workflow for you. Next slide. And also thinking about why, what's the purpose of doing the match? Like we know overall that this is a performance measure, but when you think about the technical aspects of actually conducting the match, what's the purpose of doing that and why it's important to name that and describe that within your data sharing agreement so that you can actually be able to meet those needs or those demands. And also thinking about what's going to happen with that match data, like what are those next steps and why it's necessary to outline depending on your organizational requirements and needs within that data sharing agreement. Next slide. And finally, how is the data going to be shared? How often is the data going to be shared or how often are those matches going to be conducted and in which direction? So are you going to decide between either Medicaid or HIV surveillance, if it's going to be a one-way or unidirectional data usage, or is it going to be bidirectional? You know, how does that work within each agency's context, and what makes the most sense, and what are those restraints, and how can you develop a data sharing agreement that supports that level of work? Next slide, please. So here at this checkpoint, this is where we really get to operationalizing, just transferring the data and conducting those matching processes. And so I mentioned before, you know, just being able to answer some of these questions, not only when it comes to developing the data sharing agreement, but when it comes to actually standardizing that within an operating procedure for your organization or for your agency. And so some really important things to consider here are, you know, how are you going to account for quality assurance and validation of that data? You know, who again is going to be conducting the match? Do staff have the access to the tools, the expertise, the troubleshooting, the support to be able to do that? The data matching algorithms, you know, what are those sets of instructions that are going to guide the matching process? And what types of matches are you going to do? What linkages are you going to rely on in order to conduct these matches? You'll also consider what tools or software, you know, are you going to use SAS, Link Plus, LinkKing, SQL? Like there are so many different platforms that you can use to conduct the match. And often we find that whatever an organization is currently using or has used for other projects of this scale seem to work. However, if you identify that there may be some additions or some changes from, you know, your typical matching software, you know, being able to define what that looks like and determining if you have what you need to support staff and being able to do that. It's also really important here to conduct those data quality checks, you know, so you've got the data sharing agreement in place, you've done the transfer, and you're starting to match that data, and you're getting closer to actually doing the calculation for the measure. Are you making sure that, you know, those data quality checks are in alignment with the technical specifications? So for instance, this might mean, you know, excluding people under the age of 18 or people who have not had a relevant visit within the calendar year. On the other hand, this would also include keeping people who meet specifications but don't have labs, or people who might have died within the measurement year. And those are just some examples of making sure that, you know, you are aligning your results with those criteria. Next slide. And getting to the really good part is just actually doing the calculation and submitting the measure. So again, just making sure that, you know, you're agreeing on, you know, who's going to do the reporting, like what those roles are and what they're defined, and making sure it's reported by the final piece of that year, which is in December, hopefully 2024, if you've already had these conversations. But that is the end of the year, which we hope that that measure will be reported. And also checking for discrepancies. You know, if you've been doing this for a while, or if this is your first time doing the reporting, how are you going to validate what you're seeing? You know, are you going to compare against yourself, other viral load suppression, like either at the state with Ryan White, just making sure that you kind of have that in mind in terms of validation, and then also documenting any variations from that official CMS guidance. Next slide, please. And then finally, when this becomes routine, using your SOP to guide what routine calculation looks like. And in addition to that, thinking about how you're going to use the data beyond reporting. So what does that look like? You know, how is that data, how are those results going to be used to guide quality improvement and other activities? So our goal, of course, is to get you to reporting the measure, but we know that beyond that, there are some enhancements that you can consider that utilizing this type of data is really key for. And so I will pause there, and what I'll do now is pass it on to Brittany, and she will go into a little bit more detail about hopefully how we can support you in supporting or reporting the measure. Thank you.
Thanks, Kaniqua. Greetings to you all. I'm Brittany Harrison, Senior Manager with NASTAD. Next slide, please. Our project team looks forward to working with each of you to support each core task highlighted for reporting the measure. That can look like a variety of things, such as individual meetings with states to fine-tune details such as walking how to work across agencies, building a comprehensive data sharing agreement, or establishing data workflows. Or it can look like group activities such as our community of practice that'll be kicking off soon in our in-person convenings. Last but not least, there's an opportunity for funding. On the next slide, there is information, an email, and a QR code you can use to connect with us to learn more. Next slide, please. Let's remain on this slide for just a few minutes to allow people time to capture this info as I hand it over to Van to kick off our Q&A.
Thanks, Brittany. We are taking a quick look here at our time, and we're a few minutes over our schedule, and I'm not seeing, let's see, I just saw one pop up here in the Q&A chat. So maybe we'll take this one question and then we'll jump into our state presentations. Let's see, Taniki asks, is this measure expected for use with CMS or the surveillance units? This is a CMS measure. This is a Medicaid Adult Core Set measure. In order to calculate it, it does require HIV surveillance data from EHARs is kind of the gold standard that we've established. There is an alternative method to use health information exchange or clinical data, but we're not going to get into those details today, but good question. Let's go ahead and jump into our state presentations, and we'll have that QR code at the end as well. So without further ado, I welcome Joyce to talk here from Iowa about Iowa's journey to reporting the measure.
Thank you, Van. My name is Joyce Mbugua, and I'm the Data and Epidemiology Program Manager with the Iowa Department of Health and Human Services. And I'm glad to be here to share Iowa's journey towards reporting the HVL-AD measure and to share the progress we've made so far with implementing the measure. So next slide. When Iowa joined the Learning Collaborative in 2021, we identified a number of core objectives that we wanted to meet. First, we needed to establish a high-quality data matching process between HIV surveillance data and Iowa Medicaid claims and encounter databases. And then to meet the objectives of the measure, to understand the specifications of the HVL-AD measure in order to calculate and report the measure annually to the CMS Adult Core Set. And then for us to strengthen interagency collaboration. When we started this work, our teams were in different agencies. HIV surveillance and Ryan-wide programs were in the Department of Public Health, and Iowa Medicaid was in the Department of Human Services. So establishing process for interagency collaboration was an important priority for us. And that groundwork has really helped us as we have moved towards a single department since our agencies merged last year. And then finally, and most importantly, to utilize this measure to improve care and increase the proportion of Medicaid beneficiaries who achieve viral suppression. Next slide, please. So to meet our objectives, our very first step was to execute a data sharing agreement between the Bureau of HIV, STI, and Hepatitis and Iowa Medicaid. Having a DSA in place would allow us to meet the legal and confidentiality requirements of both the HIV and the Medicaid data. And to do that, we had to engage additional department teams, including data governance, legal, and leadership from both public health and Iowa Medicaid. And they were very involved in spelling out the terms of the data sharing. We also defined the specific variables and the diagnostic codes that would share, the frequency of sharing, and define the secure sharing process to ensure that our data was protected and it would be used as specified. And then on the care delivery side, we also had to consider that Medicaid beneficiaries living with HIV were case managed through two different systems. They were managed through the managed care organization on the Medicaid side, as well as the Ryan-wide Part B subrecipient agencies. However, our two case management systems had no relationship. So we identified the need early to improve coordination between the Ryan-White and the MCO case management agencies in order to improve care delivery for Medicaid beneficiaries. Next slide, please. So with Tia from the SCIP team, we defined the critical roles that we would need to have on the project team and identified experts across the two agencies and got approval for them to commit their time to the project. And we also developed a leadership engagement strategy early in the project so that we would keep our leadership informed on our progress. Next slide, please. So we used a number of quality improvement tools for each step of this project to help us break down the scope of the project and understand what we needed to make progress through each milestone. Next slide, please. So for the purposes of this conversation, I will discuss the problem statement, the aim statement, and later on discuss a little bit about our value proposition and how we use that to gain leadership buy-in. Next slide. So starting off with the problem statement, We started by assessing what we know about Medicaid beneficiaries living with HIV. We needed to know how many people living with HIV were Medicaid beneficiaries, and of those, how many were receiving care through our Ryan White Part B program. So we also assessed beyond that viral suppression rates for those whose care was coordinated through Ryan White program and those who are not in the Ryan White program. This enabled us to quickly identify areas for improvement and to define our problem statement. Next slide, please. So for the problem statement guiding us to the why of the project, the aim statement helped us to identify the how of the project. The aim statements were built around SMART goals. They were specific and measurable, and they defined what we wanted to achieve within a stated period, mostly a quarter or two at a time, and they were assignable. So we identified who would be involved in a particular goal at a particular period. And this helped us to identify what success looked like for us at the end of each specified period. Next slide, please. So the aim statements broke our project off into smaller chunks, and the process maps gave us a 10,000-foot view of the project. We identified pain points and barriers and opportunities for partnerships and collaborations to enable us to achieve our goal. And so for the process map and the aim statements, they became living documents for us that were updated frequently so that we could be able to reflect on the progress that we're making in the project. Next slide, please. And this is an important part. This was really a big aha for us. When we started working on the value proposition, we were able to identify key stakeholders and groups that would help us to identify why we were doing this and connect it to the mission and vision of our organizations. So we identified stakeholders and the types of policy and programming they had influence over, and how our work would meet the goals of their work in a resource-mindful area. And this became a really big part for us to be able to identify what we were doing and connect it to what our overall mission for both organizations, for both teams and for both groups, and how it helped us achieve our goals. Next slide, please. So by thinking through the strategic goals of our two programs, we're able to articulate how utilizing existing structures within the Ryan White and the MCO case management system could be used to improve service delivery in a resource-mindful and used as a low-barrier solution. Next slide, please. So I want to talk very briefly about how calculating the HVL-AD measure helped us to identify gaps in HIV health outcomes. Next slide. So starting globally in a big picture, over the last few years, Iowa has ranked first in the nation in HIV viral suppression rates. We have over about 3,000 people living with HIV in Iowa, and 81% of those achieved viral suppression at the end of 2022, which is significantly higher than the national average of 65%. Next slide, please. So when we completed the data matching and data validation and verification processes, we found that just a little over 1,100 people met the eligibility requirements for the HVL-AD measure. That includes people diagnosed prior to and within the first 90 days of the measurement year and had at least one medical visit within the first 240 days of the measurement year. Of those, 90% achieved viral suppression. So we had really, really high viral suppression rates. And we spent a little bit of time breaking it down by subpopulation group. So looking across the different populations to assess viral suppression, we also found that when we did that, we found that within the subpopulations, we still had really high viral suppression rates. So our question was, how do we implement this measure? How do we identify gaps? Next slide, please. So we moved forward to assess the rates of viral suppression for those who are receiving Ryan White services. And we found that these were even slightly higher, with 91% of Medicaid beneficiaries living with HIV attaining viral suppression in 2022. So our question still remained, how do we implement this measure? Next slide, please. So when we took the next step to assess the rates of viral suppression for those who did not receive any Ryan White services, this is where we found our first gap in health outcomes and where we really were able to identify where we could take action. So we compared those to those who received the viral suppression rates for those who received Ryan White services only 77% of those who achieved of those who are not in Ryan White services achieved viral suppression in 2022. So a definite gap and a definite disparity for us to work on. Next slide, please. Since Iowa is a low morbidity state and our numbers are rather small, we decided to not only live within the bounds of the eligibility requirements of the HVL-AD measure, but to look across that, beyond that, to assess rates of viral suppression for those who did not meet that requirement for one medical visit. And that also added for us more insights so that we could be able to implement the measure and look and identify strategies to move people towards viral suppression. So looking outside of that, we found that not only were the numbers higher, the proportion who attained viral suppression in those groups were lower. So real disparities were existing in there, and they enabled us to identify strategies to move people towards achieving viral suppression. Next slide, please. So how do we move data to action? How do we operationalize this insight? Next slide. So we know that case management works to deliver quality, cost-effective care by linking the patient, the physician, members of the care coordination team, the payer, and the community, and to move the patient towards improved health outcomes. Iowa's Ryan White case management system is designed to as a differentiated service delivery model, where the client is centered, and the approach is simplified and adapts in intensity and frequency of services depending on the needs of the client. So kind of a right-sized care depending on the needs of the client. Next slide, please. So members are not disenrolled from case management, rather they're moved between tiers based on their needs. So the tiers are designed to adjust to the client's current needs. So from when they need ongoing support to actively engage in medical case management, to when their needs are minimal and infrequent, and everything in between. So clients do not leave the system, they just move between tiers depending on their current needs. Next slide, please. So we thought about this and applying this towards the system that we found ourselves in. So going back to the beginning, where we knew that our clients are managed through two different systems, but our two systems did not communicate with each other. So our strategy was to find a link between our two systems that were case managing our clients and identify areas in which we could refer them from one system to the other so that we help them to move towards viral suppression. And so we have developed a systems level approach to coordinate the system between Ryan White and MCO case management that creates a referral system and connects the clients to services through the Ryan White system to meet their needs and support them to achieve viral suppression. Next slide, please. Right now, where we are is we're developing a sustainability model so that we can identify the knowledge gaps and information gaps between MCO case managers and identifying where they need to be trained on HIV care delivery and on our Ryan White system, and create those connection and loops to our Ryan White system so that they are able to refer their clients to Ryan White case management for movement towards viral suppression. So I will stop there and hand it back to either Elizabeth or Van to move us next to the next person. Thank you so much.
Thanks, Joyce. And I'll just take a quick second here and introduce Parker from Maryland, who's going to give us a similar journey on Maryland's journey to report the measure. Thank you.
All right, thanks so much, Van, and thanks, Joyce, for that amazing presentation. So yes, my name is Parker James. I'm a policy analyst at the Hilltop Institute in Maryland, and I'll be providing another case example of Maryland's experience in the collaborative. Okay, so in Maryland, this was really a team effort between 3 different organizations and the leadership and staff at those organizations. And so we have Maryland Medicaid within the Maryland Department of Health, HIV surveillance, which is in the Center for HIV Surveillance, Epidemiology, and Evaluation, also within the Maryland Department of Health. And then the Hilltop Institute, where I'm a policy analyst. The Hilltop Institute is a nonpartisan research organization at the University of Maryland, Baltimore County. And we have a longstanding relationship with Maryland Medicaid. We actually house the eligibility and claims information in the Maryland Medicaid Medicaid management information system. And so we're able to do a lot of data analysis and support for the Department of Health, including putting together a lot of the core set measures. So this group was really primed to participate in the collaborative. Maryland had participated in that HIV affinity group project that was mentioned earlier. And through that project, we were actually able to establish our initial data sharing agreement as well as preliminary matching process. And also through participating in that initial affinity group, the leadership from all three of our organizations really had seen the value of this work. And so we were really excited when this opportunity came up to advance the work further and report the measure. So I'll be talking a little bit more about how this project allowed Maryland to improve our data matching, report the HVL-AD quality measure, and strengthen our collaboration in the process. Next slide, please. Okay, so even though we had a good foundation going into this project, we still needed to take some steps to build to reporting. And the first was that we needed to renew our data use agreement. And we really focused on, sustainability and flexibility when kind of working to renew that DUA. And that meant expanding the years of analyses, making sure that we were going to be able to do this many years in the future, taking a careful look at those specifications for the HVL-AD measure, making sure we were including all of the data elements needed, as well as what we would want for subgroup analyses and other sorts of data elements that might be helpful to develop quality improvement projects and things like that. We also made sure, as a group, to understand the amendment process. Everyone was familiar with, if we wanted to bring a new partner into the project, for example, what would that look like? So we made sure to all be on the same page as we were working through renewing our DUA. Our team worked really closely with NASTAD and partners to, at the same time, begin to develop materials that would set us up for success once we were able to share data. So our process map and task diagrams were really helpful because they mapped how data were going to be transferred between Medicaid and HIV, how data was going to be reviewed, the quality assurance steps that would be built in. And so we met frequently to develop our action plans, our aim statements, those tools that Joyce shared. They were all really helpful in terms of setting us up for success. So next slide, please. So here's an example of Maryland's process map with quality assurance steps. And this was also a living document. So it didn't start out this way, but this is sort of where we are now. And it really does trace the flow of data from when the patient visits their provider through to getting a lab test, that data in the HIV system being matched to the Medicaid claims and eligibility information to establish our cohort for the measure. And from there, we needed to flag who had a visit, who was over 18, all of those little things built into the specifications to eventually generate the measure, disaggregate by different subgroups to inform, strategies going forward, report to CMS, and really repeat the process, continuing to refine our matching and quality assurance. Next slide, please. So we wanted to make sure too that we were designing with the future in mind. So like I mentioned, when we were renewing our DUA, we made sure to really carefully review our existing language and make appropriate updates to allow for the kinds of analyses that we were looking forward to doing, in addition to just putting together the quality measure. And an example is that we discussed, potential use cases, policy implications. Maryland is a predominantly managed care organization state, so we talked about, what would it look like to bring the MCOs into this project, inform them, and potentially do some data sharing, or local health departments. So we had an idea of who, additionally we would want to bring into the project. We made sure to extend our DUA beyond the formal end date of this collaborative, because we knew that we would report the measure annually, after the collaborative ended, and continue to want to use the data for quality improvement. We worked together as a team to create feasible and replicable quality assurance steps for data matching between HIV and Medicaid, met on a monthly basis, as partners to figure out what would be the most, feasible process, who's reviewing the matches, and that sort of thing. And then making sure to document all of our policies and procedures, and putting together that standard operating procedure was really helpful in case there are staffing changes to the project. Next slide, please. So just wanted to provide an example of the kind of help, that participating in a collaborative can provide. So we learned from peers a little bit more about helpful strategies for matching. We were already pretty satisfied with our match. We use basic demographic variables. So first name, last name, date of birth, social security number, Medicaid ID, in SAS to match between the EHARS data set from HIV to Medicaid claims and eligibility. And, we would basically rank these matches. So if somebody matched on all of the different variables, they were a strong match. But if they only matched on one, say Medicaid ID, for example, it was a weaker match, and we knew we needed to do some more review. And the review was happening on the, our HIV partners were taking a close look at those cases. And they did find that it could be quite time intensive to determine whether or not this person was a true match. So by participating in the collaborative, we actually learned from a peer state about a method where we could use a file of all possible name variations, or an alias name file on the HIV side, to make that match a little easier. So just as an example, my name's Parker James. It often gets flipped to James Parker, or maybe, Patrick James or something like that. So by using this method, we would pull all of those different variations that have ever been submitted for a person on the HIV side. They're all linked by a common ID, and then we would match each record to Medicaid. And we were able to really improve the strength of the matches. So some matches went from weak matches to strong matches, and then some that were indeterminate were able to be determined through this process. And it just sped things up overall. So just an example of the kind of peer support that's really helpful by working with NASTAD and other partners in the collaborative. So next slide, please. So we were able to succeed and report our measure for this calendar year 2022 or federal fiscal year 2023 core set reporting. Our HVL-AD rate for calendar year 2022, a little lower than Iowa's at 74.8% suppressed. This is higher than the overall suppression rate for Maryland, but we know that we want to take steps to improve these rates. We also knew that this overall rate, wasn't going to tell the full story, and so we worked with NASTAD to really focus in on disaggregating the data by some key populations. So age, race and ethnicity, region, fee-for-service and MCO, and also looking at some comorbidities like behavioral health. And these data were also really helpful in terms of presenting the data to stakeholders. So once we had our measure and we were able to disaggregate, we wanted to get some more feedback from partners about what might be helpful, in addition to just sharing this work and letting them know that we've been able to do this. So we presented to our MCO stakeholders at an MCO liaison meeting that included both leadership and staff from different MCOs in Maryland, as well as the Maryland HIV Planning Group, which includes state and local health department staff, providers, and community organizations and members. They were really excited to see the data. They wanted to get their hands on the data to take action. So we're continuing to work with them to take some next steps to improve care for people with HIV in Maryland. Next slide, please. So to summarize, this was really a valued partnership. Through participating in the collaborative, Maryland has created this linked Medicaid HIV data set that can be used not just to report annually, but to refine our HIV analysis and evaluation within the Medicaid program. And so there's an enhanced understanding of, the processes of how HIV surveillance works and Medicaid claims data, how they interact among the partners that have participated. And these data really provide additional opportunities to inform policy and quality improvement strategies going forward. So participating in this multi-state collaborative has provided such insight and guidance for us. We've really learned from the peer states in the network to create a robust and well-documented process to match our HIV and Medicaid data. So next slide, please. It's just a little bit more information about the Hilltop Institute. And on the next slide, I think it's just my contact information. So thank you all so much. I'm going to pass it back to Elizabeth for Q&A.
Thank you so much. So I think these were a couple of fantastic presentations from Joyce and Parker. So I just hope that folks will join me in thanking both Joyce and Parker for those. I want to give folks a little bit of time to think about what questions they might have and think about sharing those in the Q&A box. But before we get going with that, wanted to just get a little bit of conversation going to hear a little bit more about your experiences. So this was, fantastic to see kind of each state's journey, and there are ways in which you each had sort of your own unique kind of story to and road to reporting the measure. But I wonder if you could each say a little bit about what the sort of initial buy-in or interest for reporting looked like, and how that was established in each of your states. And just for others on the line, I think that this is a really critical part of the process. If you want to set yourself up for success, and you really need to get all of those stakeholders aligned and get that sort of political will in place. So let me start with Joyce. What did that look like as far as getting buy-in together?
So getting buy-in for reporting the measure was not necessarily difficult because our Medicaid counterparts already had a practice of calculating and submitting other quality measures to CMS. So that piece was relatively easy. The piece that we had to work on was actually getting the data so that we could actually calculate that measure. So Iowa participated in the affinity group that was in 2016. And since then, and all the way up to 2021, when we joined the collaborative, there was work going on in the background to work on a data sharing agreement between our bureau and other bureaus within public health, and sharing the data sharing between them and Medicaid. And so that piece was kind of the big lift that for us turned the key so that we could calculate and report the measure. So getting the right people in the room, the data governance team, the legal team, leadership in the room, and our team, so that we could help to explain why we needed to match the data, why the measure was important for us, and what we needed to do with it was the piece that really developed, one, an understanding for what we needed, and two, leadership buy-in so that our leaders understood why we needed to do this. So there was a lot of work that was done on that piece. And fortunately for us, we got it just at the right time when we joined the collaborative. So being in the affinity group really helped us get a sense of the need to be proactive about getting that data sharing agreement in place. And it really turned the key for us to be able to move forward in the project.
Thanks. And let me just quickly follow up before turning to Parker. You said, it was really important to get all of those folks in the room and sort of get them on the same page about the importance of this. Were there key points that were particularly resonant that it might be helpful for others on the line to hear?
Yes, I think for us getting data governance in the room, because they had we have in the department, we have a long tradition of working on data sharing agreements. So getting data governance in the room and helping them to understand exactly what the data is for, and then who we can get to actually do the matching. So explaining the expertise on the team and how we would be able to secure the data, both our data and Medicaid data, because both of them have really high confidentiality requirements. So that piece needed to be explained really critically. And then giving them the ability to translate that to legal, so that they're able to talk to legal in the language that legal understands, and then getting our leadership and Medicaid leadership in the same room, and so that they kind of have a larger, broader sense of what we were talking about. So I think it just was at each critical point, we had to get the right people in the room and get them to understand what we were talking about.
That's great. And I actually really love your points about sort of making sure that people are speaking the same language. I think that's often a real challenge. So Parker, let's hear a little bit about Maryland's experience.
Sure. So Maryland's experience was similar. I think for the partners involved, you know, we had also participated in the affinity group, and we're really just excited to kind of take this to the next step, which was reporting. And I think that the partners recognize that, you know, it can be a lot of work up front to kind of get the match working correctly. We had done, you know, the preliminary match, but we hadn't really taken it to that next level of, you know, then using that data set to put together the measure, checking for visits, checking for when the diagnosis happened, all of that stuff. And so by having the resources, you know, of NASTAD, other states, the research partners, you know, being able to really help us through the process, I think that was really such a boon to our efforts, and we were really just excited to participate. And that said, I mean, we definitely in Maryland, it aligns with existing priorities, you know, so ending the HIV epidemic, as well as quality measurement. Like I mentioned, you know, Hilltop has been assisting with putting together other adult core set measures, so it fit really nicely. And also Maryland has, you know, been prioritizing health equity. And so Elizabeth, the kinds of connections that you mentioned, you know, were aligned in Maryland as well. And so, yeah, we were just excited to get started and knew that with NASTAD support, you know, it would be a success. So.
Great, thank you. Yeah, it sounds like there was a good amount of sort of dot connecting with the different initiatives and strategies that are out there in terms of both nationally and across the state, to sort of be able to say, hey, look at how well this aligns with all of that. And then, you know, so that's great. I want to ask you all, and I'll start with Parker this time. When you think about, and when your teams, I guess, think about this particular measure, where do you see the greatest opportunities and the ways in which this measure may benefit your state in particular? And you can think about this in terms of outcomes improvement, as well as some of those interagency collaboration or infrastructure components as well. So just think kind of broadly and think about, where do you see the greatest opportunities this measure provides?
Thanks, Elizabeth. Yeah, I think in terms of, you know, outcome measurement, we didn't really know, you know, where we stood. And so now that we put together the measure, it's really helpful to just have that. And, you know, we actually put together a preliminary measure for 2021 as well. So we've been able to begin to track how things are changing over time, you know, trying to run the measure a little more frequently than annually too. So just hoping to get a sense of how it's changing. So really excited about that. And, you know, in terms of like presenting the data to our MCO partners, you know, they were excited to find out about the project, that this data linkage had been happening. And so I think it just opens a lot of opportunities for action and quality improvement that, you know, we're thinking through. And also in terms of, yeah, the strengthening collaboration, you know, the interagency relationships, that has been really great and pivotal and exciting, because, you know, now we know who to contact with questions related to, you know, HIV/AIDS. And so we were able to, just as one example, Hilltop also puts together, you know, annual evaluation reports of Maryland Medicaid and the Health Choice program, which is the MCO program in Maryland. And so we were able to refine our HIV and AIDS evaluation measures in our report, through working on this project, talking closely with our partners in the Center for HIV Surveillance. So yes, on both fronts, both in the outcome side and just interagency connections, a lot of exciting opportunities coming out of this.
Thank you. And I think you made, a couple of great points I'd like to highlight is, the first kind of being like, you don't know what you don't know. And so some of the value in having the measure at first is just being able to see what the situation is. And from there, it kind of opens the doors in terms of, all right, well, now we at least know what the story is. And so let's think of all the different ways we can kind of dig into that and get a more nuanced understanding, and then think about where the improvement opportunities are and make sure that we're fitting those with what the data are telling us, right? So it's very much making sure that you're taking a data-driven approach to improvement, which is fantastic. And then I heard in the latter part some great examples of the ways in which this work led to collaboration that went beyond the measure, right? And made you, helped you all do some work to improve how you're measuring things a little bit more broadly, and think of other ways to maybe get strengthened collaboration between the two agencies, which is great. Joyce, let me turn to you and talk a little bit about the greatest opportunities that Iowa sees for this measure.
So I think it is in the relationships that we're building with Medicaid, and farther than that, the relationships that we're building with the MCOs. So I talked a little bit about the team that we built when we started the project, and I think that became such a treasure trove for us, because we were able to get people from Medicaid who had real expertise and were sitting in really critical positions to help us understand the Medicaid system, not only their data, but also quality management team, what they do, the HIV waiver, what that is, policy, and how to get engaged with the MCOs. And so that piece for us, I think, is one of the biggest things that has come out of this, is that we are moving towards developing that kind of linkage between the two case management systems, so that we are able to help people who are not achieving viral suppression within the Medicaid system, get connected and referred to the Ryan White case management system, which has proven to be able to move people towards sustained viral suppression. So that piece is just, it's such a great outcome of this project, which going into it, we kind of wanted that, but we didn't know how we'd get there. So having all those people on the team able to move us along step by step to get us there has been really fantastic. It's been a really great benefit of participating in this.
Yeah, and you had such wonderful slides kind of showing and highlighting those things as well. And I think what was great about some of those examples was the way in which, it's important to think about, and I kept in my remarks pretty strict to what the measure is, but there's a lot of opportunity to kind of adapt to the measure and peel away and adjust the specifications in little ways that help you learn other things. And so once the agencies are sharing data, and you have all of the building blocks, you can start adapting however you need to help that sort of build that improvement story, and better understand sort of where the challenges in your state, where are the opportunities for improvement. And this was a way that you all were able to use that to also strengthen relationships across the different units, which is fantastic as well. So I'm just going to, because before we turn it over to some broader Q&A, I'm going to ask each of you to reflect a little bit on your respective journeys in your state, and think about sort of what your key takeaways would be. So if there are states on this webinar that are listening in that don't report yet, but that may be thinking about it, what do you most want them to know as they are starting their sort of journey to reporting? What would be, just a couple of key takeaways that you would want anybody to know who's not doing this yet, but is thinking about getting started? And I'll come to Joyce first.
So I would say get the right people right away. And this for us looked like really sitting down with the project scope and identifying who we needed to get involved right away. So we knew that this was going to be a data matching project right away. So we needed to get HIV surveillance people and Medicaid data people involved right away. So we needed the people with the expertise who were in the data, would be able to match the data. Beyond that, we needed leadership support. So we needed to have a sponsor on both the public health side, our bureau side, and on the Medicaid side. So getting those people who would serve as the people who talk to leadership for us, so that we can be able to get people who are going to dedicate their time to the project was a really, really early need that we identified and we deployed very quickly. And then beyond building the team that is going to work on this, getting involved, the TA team, the SCIP team was really the people who held our hands and got us there. And so chopping up the project scope into smaller segments helped us because it was huge starting off with. And we needed to kind of take small bites at a time to be able to move along. So kind of developing a model or designing a model, and which the SCIP team already has done, that segments the project so that we're moving towards reporting, but more than that, to have a real understanding of what you want to do with the data, because it's fantastic to be able to match and to be able to report, but then we have to move data to action. And so what do you want to do with that data once you match it and you have all of that fantastic information and insights that you've identified from the data? What do you do with it? So those are the key things that I would say if a state is interested in getting the measure calculated and reported, to kind of take a breather and think about who do you need to be at the table, who can talk to leadership on your behalf to keep things moving along, what are you going to do with the data afterwards, and then utilize the skill set that we have on the SCIP team and at NASTAD to kind of chop up the process so that it gets you moving along.
Fantastic. Yes, definitely breaking things into sort of baby steps and actually understanding what that roadmap is huge. But also, it sounds like knowing who the right people are and then having friends on the inside, right? That can help you with that. Parker.
Yes, I agree with everything Joyce said, really helped us too in Maryland. I think that one thing I would say additionally is, if you feel like maybe you're getting stuck on a piece, like I know the DUA can take a while, amending a DUA can take a while. And so, I think just continuing to kind of do what you can and move forward where you can. So I think something that was really helpful for us is while we were waiting for our data use agreement to get renewed, really taking a close look at like which variables are we going to be matching on? How is the match going to work? How are we going to do this? Putting together that process map, like those are all things that you can, do if you're in waiting, and just getting a good understanding of the data. I know it can be hard without having like specific examples to look through and things, but the more work you do up front, the smoother it'll be kind of once you're able to share data and get going there. So yeah, in addition, thinking through data uses and things too is really helpful in terms of if you want to set up a report that runs, quarterly or something, what needs to be included in that, what kinds of quality assurance checks do you want to do every time, all of those things are really good to think through as early as you can. So, and then refine, tweak, get feedback from, NASTAD and other partners. So, yeah.
Great. Thank you so much. I am gonna turn things over to Van, but just thank you very much again, Joyce and Parker. I think this was great. And I think we are going to broaden it up and have a little bit broader Q&A with Van. So thank you.
Yeah, thanks again. Just underscore Elizabeth's gratitude for our state telling their story, spending some time here with us today. We've been keeping a really close eye here on the Q&A pod, and we've answered a couple questions there, as well as the chat. I think that we provided a lot of information today. I'm going to give you all just maybe 20, 30 seconds. What questions remain for you? Drop them in the Q&A chat. And while you're thinking about that, I'm just going to highlight the questions that have come in so far. So there were some questions about who is actually doing the reporting of the measure. Again, that's within the Medicaid department via their typical adult core set reporting processes. Kimberly asked about the stakeholders, and we spoke to those pretty extensively. And then Leah here, I think, really narrowed in on the biggest first barrier that almost every state encounters, and it's the aspect of buy-in. And so I saw Elizabeth clarifying there. We can speak to strategies to build both Medicaid buy-in and Department of Health or HIV surveillance buy-in. But I think what I'll say is that Elizabeth mentioned the word baby steps, and I was thinking that the first step for a baby is often the hardest. It's going to be maybe the hardest step that they've had in their lives, obviously, thus far. And that's certainly the case that we have found with this project as well. Many states getting this initial buy-in is really has been the toughest nut to crack in some cases. Parker alluded to this a little bit, but step one is really planning your plan. Your plan can look a variety of different ways and will require various levels of buy-in depending on who's doing what. So in some of our states, the Department of Health is doing the heavy lift with the match, calculating the measure, and then they're just sharing back an aggregate rate with Medicaid to report. Whereas in other states, Medicaid is actually doing the heavy lift and they're receiving the data and reporting it there. So again, it really depends on your plan, planning the plan. I'm going to take just maybe 10 more seconds here. I'm not seeing any other questions come in, and I take that to mean that we have done a thorough job today, an exhaustive job, not exhausting, but an exhaustive job today of showing you what it takes to report this measure.
Van,
please.
Let me just jump in, because just in case, if Leah's asking about sort of buy-in within Medicaid specifically, I think one thing I'll acknowledge is that that can be challenging to do because of the many competing priorities the agency has and the things that they're weighing sort of beyond HIV. And then particularly at this time when there's also unwinding and there's a lot of other things going on. And I think Medicaid also gets a lot of political scrutiny within states. And so there's a lot for stakeholders to balance there. And sometimes it can be challenging to get this priority to rise to the top. And so the thing that I would say is to try to emphasize importance from the perspective of Medicaid, right? So why is this measure of such value when you think about, you know, how many people are have HIV in the state, how many people, if you have the knowledge of it, are virally suppressed or not, and trying to get an understanding of the magnitude and also how much HIV costs in the state can be important. And so trying to get a sense of what the impact of improving viral suppression in your state could be. Again, that alignment with national quality strategies and whatever the state quality strategy is going to be really important. Thinking about the ways in which there may be resources that exist that make this not a huge feasibility barrier. So trying to identify, you know, what resources maybe exist through what's coming out through NASTAD or through others. Maybe there's a partially existing data use agreement that you can adapt. Like what could be done that could make this not a heavy lift for the agency? And then also, again, thinking about what are the opportunities within the state to roll this into existing policy infrastructure? Where can this measure be used? And where could you get sort of uptake of the measure relatively quickly to show impact? And so those would be some of the things I would think about if you're trying to achieve buy-in within the Medicaid agency.
Thanks, Elizabeth. And I see Dr. Cheever coming off camera here. We've got a few words of closing from Dr. Cheever, Associate Administrator, HIV/AIDS Bureau, before a quick call to action and our evaluation QR. So don't run away after Dr. Cheever has her comments here. Dr. Cheever?
Great. So first and foremost, I just want to thank you for participating in this webinar. And especially thank you to the presenters for sharing their experiences and underscoring the value of these activities that they bring to the day-to-day work. I think many of you have heard from us that we were really making sure that we are focusing on people that are out of care. And I think when you look at these viral suppression rates, you can get a much better sense of that. So I think this is important. In terms of this initiative, it's not only going to achieve its intended purposes of assisting states to report their viral suppression data to the Medicaid Adult Core Data Set, but also will result in other positive changes that I think you all were just discussing. First and foremost, I think for us, something we do all the time at the federal level, and I know you work on at the state level, is to really improve that relationship between the state Medicaid and the HIV programs. I think you heard from Maryland and others that this is really building layer upon layer. So we know that you just can't start off and get it all done at once. But as you proceed in this and other activities, you will deepen that relationship. So I'm really excited about that. And also to really make sure that these data are being used through data into action, I think was also just discussed, to really talk about the importance of making sure that we're using these data to help strengthen care coordination and continuity of services for people with HIV across the state, especially as Medicaid has moved into working on some of the issues around social determinants of health and some of the expanded, or not expanded, but of the new authorities, or not new authorities, but the authorities that people are really thinking through in the last couple of years in terms of how Medicaid can really look at things differently and have different expectations around housing and transportation and some of those other benefits potentially embedded in Medicaid. And I am pretty confident that this really will have a lasting impact in this initiative over the years to come. Those who've been involved have really been able to map out and implement workflows with their Medicaid and with the support of NASTAD and their partners. So we were really interested in learning also how to expand some of the work that you're doing to others and disseminate what are those lessons learned. So in closing, I also do want to thank you for the work that you all do every single day to support the well-being of people with HIV in your state. The role you play is obviously very, very important. The Ryan program is as successful as it is because we have this healthcare public health interface. So please take care of yourselves as you continue to care for your staff and the people that are directly impacted by the program. And with that, I'll turn it over to our NASTAD colleagues. I also do want to show deep appreciation for all that you do and the true partnership that we have in the work that we do. So thank you.
Thank you, Dr. Cheever. Next slide. All right, get your phones out. Take a quick picture of this slide here. If you're a new state, if you're not reporting, join our monthly community of practice. In addition to our monthly meetings, we'll have a listserv where you can connect and collaborate not only with NASTAD and the team and the resources that we have here, but with your colleagues and your peers who are doing this work in other states. So that top QR code will take you to a quick form. We're just asking for your name, email address, and we want some of your preferences on topics and times that work best from you. And I'll be remiss if we don't have a quick evaluation here. The bottom QR code is a quick evaluation that we have for our webinar. I'll leave this up here for just a moment as we go ahead and close on out and say goodbye. But again, take your phones out, take a quick picture of this, come back to it maybe later today, or just complete them right now. But again, join our community of practice if you are interested in moving towards reporting this measure in your state. Take a look at the chat quickly as well. We put the links in there, both for the QR code for the form and for the evaluation. And that's going to be it for us today. Again, I just want to extend a huge thank you to our team, to HRSA, to all of our federal partners that have helped support this work so far, and our partners at AcademyHealth, at GU, at UCSF who have made this work possible. Thanks, everybody, and have a great day.